Hello, this is Glenn Krause from AE and Associates with another great podcast, Preventive Denials, a New Approach to CDI. And now today, the privilege of being with Dr. Jake Martin. I've been working with Dr. Martin for 28 years now as a colleague, traveling throughout the country as physician champions and advocates. Dr. Martin, welcome to the podcast. If you want to give a little background about yourself, I'd appreciate it.
Okay, thanks, Glenn.
Yep.
I'm a former emergency room physician, had many years of experience in the emergency room, also preventive medicine specialist. My permanent and current board certification is through the American Board of Preventive Medicine. I also hold a non-ABMS certification through the American Board of Quality Assurance Utilization Review Physicians, which is renewed every 2 years. I've also had experience in sports medicine, as well as insurance medicine. I spent 12 and a half years as a medical reviewer for an insurance carrier.
Thank you very much, Dr. Martin. So today we want to talk about preventive denials, a new approach to CDI. Dr. Martin and I have been saying for a long time, or promoting the idea that CDI really needs to transform itself into a more proactive approach. So I come up with some discussions that we want to have today. Now, Dr. Martin, you've been working with a number of community hospitals in multiple states over 10 years. In various capacities, you and I working together, but most recently in the last few years, we've been conducting peer-to-peers in an attempt to overturn payer denials. You have been very successful in overturning these denials on appeals, a phenomenal 70% overturn rate. What are the biggest challenges in overturning these denials? What is the most limiting factor that you're facing right now?
Glenn, in virtually every level of care denial, it can be traced to insufficient medical documentation, whereby to cogently depict the patient's clinical story from one day to the next during the hospital stay. Some Medicare Advantage plans, medical directors are now using MCG as the sole reason for upholding denials. In my review opinion, this is improper, as clinical decision support algorithms are designed for nurse-level reviews versus physician-level reviews. But in summary, it all comes back to not telling the patient story, not giving us interval histories from day to day, which reflect the need for intensity of management at the inpatient level of care.
So would you say a lot of the documentation is maybe could have been strengthened, or is insufficient, or excess copy and paste? Or is this having a factor?
Yes, excess copy and paste is almost always a factor. But typically what we'll see in interval histories is it's not concentrating on what's being done for the patient, but on the fact that the patient has no new complaints. There were no significant adverse events overnight. The patient's doing well, and that's it. That's the interval history. Well, when the external reviewer looks at that, the only question is, what time will they get home today? There's no medical necessity for an inpatient level of care communicated in that interval history. And we'll see that same verbiage copied and pasted from day to day. So I think that, copy and paste expedites medical record completion, but it also has a downside as well.
So that brings me up to my next question. What should CDI be doing? What can they do better to reduce what we refer to as self-inflicted denials that allows the payers to hit out of the park? I think you used that great analogy of the T-ball system.
Yeah, historically, you and I have both observed that CDI programs are adept at capturing CCs and MCCs.
Absolutely.
However, the mere capture without clinical validation of a diagnosis will most often lead to a DRG downgrade. The other thing and we're talking about DRG downgrades and diagnoses, high severity diagnoses that are disallowed, but there's another piece to this too, because the CDI professionals should also look to see if the documentation is sufficient to support an inpatient level of care. Because if it's not, then their work is done. Anything after that point in time is really irrelevant. So they should be at least conversant with severity of illness and intensity of services to understand whether or not the record that they are reviewing, and sometimes they're reviewing it even before the case manager looks at it. If there's more documentation needed to better reflect this patient's severity of illness, then that's when the query should ensue or discussion with the attending physician.
So are you thinking that CDI should be spending more time on the history and physical and looking at the documentation or examining the documentation for conflicting or ambiguous information? Because right now most of the CDI programs wait till the day after, so that let the dust settle, if you will. But in my mind, that now that the dust is settled, it makes it more challenging to improve the documentation. What are your thoughts on that?
It's my opinion that the earlier the better, because one, the carrier looks for, in their medical and clinical reviews, looks for consistent documentation. If you're not on board till day 2 or 3, you've already lost those first couple of days. And you know, that documentation pattern is now ensconced in that healthcare provider. So I think they should look at the first day, or as early or as close to the first day as possible. And they should look to see that the history of present illness and review of systems actually maps onto the exam. Whatever is acute, acutely discussed in those areas, clinically acute, there should be corresponding physical examination to further elicit the nature of that. And in the assessment and plan, those acute things that were noted in the HPI should map to that as well. That will give consistency of documentation. It will give a clinically cogent flow of information that makes sense. Oftentimes I will see something that says a patient was more confused per the spouse when he arrived at the emergency department.
Right.
I never see anything else after that.
Nothing mentioned at all in the physical exam or anything along those lines, huh?
No, nothing about assessment. You know, and it's important to indicate whether or not this is felt to be significant. If it's felt to be, this patient may have a history of dementia, if it's felt to be consistent with the patient's cognitive baseline, that should still be noted in the records so that there aren't question marks. You know, have we missed an encephalopathic process that's acute or subacute? Or is this something that we could expect out from this patient every day?
Yeah, and I see the same phenomenon, particularly with respiratory. Dr. Mon, you've seen a few of those just recently, where the doctor said acute hypoxemic respiratory failure secondary to COPD, severe COPD exacerbation. But you look at the physical exam, and they just click down the first thing that comes on the drop down menu. Alert no times 3 and no distress, resting comfortably in bed. Those are almost impossible to appeal. Do you agree?
I agree. That's a clinical disconnect, and it's described as a clinical disconnect by the medical director who reviews it. There is a way to address that, and that's through the proper temporal documentation. The patient came through the emergency department. They got supplemental O2. They may have gotten IV loop diuretic. They may have gotten a corticosteroid intravenously. If it's felt to be a COPD exacerbation, they may have had empiric antibiotic therapy administered in the ED. And then an hour and a half later, when the attending hospitalist first sees the patient, they're not particularly in any acute distress. And there's nothing wrong with reciting that diagnosis: acute hypoxemic respiratory failure, secondary to COPD exacerbation, now greatly improved owing to the expedient and appropriate medical interventions in the emergency department. You have now given it the temporal and clinical context it needs in order not to be disallowed on medical review.
Yeah, and you know, that might seem like a small, you know, point, if you will, but it really makes a big difference on a lot of these. And I see these, I know you see in your practice, but I'm seeing a lot of clinical validation denials where maybe the clinical indicators may support a diagnosis. Unfortunately, the clinical facts or information as described and documented by the physician doesn't support the diagnosis, and the payers, they easily pick up on that. So, folks, I think it's really important to listen to what Dr. Martin said regarding looking at the documentation in the H&P and being proactive, not after the ink has dried or the document has been signed. Now we need to do an addendum, which is always suspect, which leads me up to my next point. We are all familiar with key KPIs or key performance indicators for CDI. Do they need to be revised? And if so, what should the KPIs consist of? I know we had a engaged discussion last week. What are your thoughts, Dr. Martin?
Well, one meaningful outcome not generally included in CDI program KPIs is the denial rate of charts which have been reviewed and queried by the CDI professional. Also, as the CDI program matures, it's expected that the total number of queries each month should decrease as a result of, one, interacting with healthcare providers rather than simply targeting them with queries, develop relationships with providers. Two, ongoing mentoring on high frequency, high acuity diagnoses, which are often disallowed on carrier medical reviews. And three, lunch and learn sessions not to exceed about 30 minutes per month. Number one, to cover one or more clinical topics where improvement of documentation has been a recurring issue. And two, to receive feedback from the providers about the CDI program.
I think we agree, Dr. Martin, that the current indicators kind of prevent. I believe, well, we had a discussion, and you brought this point up that the current KPIs are task-based activities, and the situation at hand. The situation at hand is that it prevents us from actually spending the time to educate the physicians. We have to review 20 to 25 records a day. We have to achieve a 30% query rate. Then we track the CCs and MCCs captured. This to me, I don't know about you, but this to me has a little correlation with actual documentation integrity. You've mentioned before recently that you've seen denials for sepsis and acute metabolic encephalopathy when this record was reviewed and queried by a physician. Were you able to overturn these?
They're virtually impossible to overturn. I'll give you an example. I saw a sepsis denial, and there was a multiple choice query rendered to the physician.
Right.
There were 7 clinical indicators cited before the queries, and then the choices, obviously sepsis, and always included in there are other, please clarify, or please specify, and cannot be determined. Well, the physician concurred that sepsis, or noted that sepsis was present. This one was denied because though the clinical indicators were there was no documentation of sepsis-related organ failure or dysfunction. So this is one that on the surface appears to have been appropriately queried, but it didn't contain. It was necessary, but it wasn't sufficient, whereby to assert a diagnosis of sepsis.
And I don't think you were able to overturn that. So, and that's I believe that was a commercial payer, and that amounted to quite a few dollars, didn't it?
Yes, it did. And most of these are, when we see DRG downgrades, this either the principal diagnosis is disallowed and or an MCC and or a CC. I've seen where they've disallowed sepsis, acute hypoxemic respiratory failure, and AKI, or that is acute kidney injury, on the same chart.
Wow, that must have been pretty painful from a reimbursement perspective.
Now, that was thousands in a recoupment.
Right, and hospitals are and I read something recently that I posted on LinkedIn from Crow Revenue Cycle that showed that the recoupments are at an all-time high. We're talking about billions of dollars here in hospitals throughout the country. And on this Crow platform, they don't have all the 4,000 plus hospitals. So we're talking billions of dollars, not even taking into account all the hospitals. So CDI really needs to take a preventive denials, a new approach to CDI. So I just want to touch base on one other area. You and I have been working together for over 25 years. We kind of agree on this, but I want to get your take. If you were going to redesign a CDI program to address insufficient documentation that was geared towards physicians, not just CFOs, what would this program look like?
Well, Glenn, quite simply, I think it would be interactional versus transactional. The physicians view themselves as targets when it comes to the query process. They want fewer queries, not more. I saw a physician one day and he just looked concerned. And I said, what's going on? And he said, I've received 5 congestive heart failure queries on 5 different patients. He said, why don't you just tell me what I need to document? What's the critical things that I need to document? If we could teach the physicians the preemptive, proactive documentation process, give them meaningful documentation tools for that toolbox, then these queries in the main go away. Some queries must be rendered, but many of them are just repetitive, and the physician gets very jaded toward the query process. And Glenn, you and I have said, let's educate versus query.
That's right.
Because that always leads to the physician being irritated. And we want to be partners. That should be a foundational aspect of any CDI program. We should know the physicians as CDI professionals. We should understand, I always say empathy and respect are 2 indispensable qualities of a good CDI professional. We need to be respectful of their time, their abilities, their education, their training, their experience. We need to be empathic with respect to the fact that they're getting hit from all sides. And we can tell them that we can provide at least a partial solution. We can mitigate some of these daily interruptions. If we can give them the tools, the basic documentation tools, then the quality nurse, the floor nurse, the UM nurse, the UR nurse, rather, the case management nurse, coding, all these people who come to them trying to get clarification, that can be mitigated and oftentimes totally precluded if they can use this preemptive, proactive documentation process.
I agree. And so, just one last thought. Where should CDI start? How do they make that transition or transformational step from I guess I would almost like say being on our training wheels on a bicycle and really get out and start doing riding that bicycle or helping physicians as mentors? Where's the good starting point?
Well, Glenn, the CDI nurses' hands are virtually tied because their performance evals rest to a great degree on KPIs. So this means that if you're going to have a radical change in a program, it requires top-down support from the C-suite down to the CDI nurses, so that they understand that they're not going to be penalized for not getting a 30% query rate once the program starts to mature, that they should have their processes tied to actual review of denials of charts which they have previously reviewed and queried, so that they understand one of the end outcomes is of the CDI query process. Could I have done this better? Could I have maybe not had to provide this query, but just simply a 3 to 5 minute brief conversation with a physician? Of course, you know, when you're doing that, you always want to document what the conversation was and what the outcome of the conversation was. But I think transactional is what we see today.
Right.
It's what turns off physicians. But as I said, the CDI professional often have their hands tied because of the KPI process. So if and until KPIs change and there's top-down support, it's going to be very difficult to make a CDI program more interactional with the healthcare provider.
That's correct, and we really need to. I would like to say in closing, first, preventive. I think certainly the key word here in the title was preventive denials. But rework is expensive. A lot of hospitals, as you know, Dr. Martin, they outsource their denials and appeals, and they charge by the record whether they get it overturned or not. So that increases cost to collect. How much does it cost to collect on this claim? If you look at the Medicare's 5 levels of appeals, we're talking about at least a year. And after the reconsideration and it goes to administrative law judge, the MAC or the Medicare administrative contractor takes back the money, and then you have to fight like heck to get it back. So I want to say, Dr. Martin, we agree that the KPIs certainly that we have today are tie our hands, as you mentioned, but we certainly can make the case by looking at the number of denials and the fact that we don't have the time necessary to really focus on true documentation integrity, helping physicians improve their documentation, because after all, only the only person or clinician who can improve their documentation is who? The physician, the nurse practitioner, or the physician assistant, with our help, assistance, and the guidance. Dr. Martin, any closing remarks?
I'd just add that the CDI professionals I've known are very accomplished clinically. They
Yes.
often have been nurses for quite some time, and this is sort of a capstone of their nursing career. And I think there's a lot of frustration at times because they're trying to work within the system with which they are provided, but they still see denials come back. So I think it goes, as we've talked about, looking very judiciously at the KPI structure. Not that, you need to jettison everything in there, but make it more realistic and more adept at identifying ways to prevent denials, whether they're level of care denials or DRG downgrades or medical necessity denials, and let the CDI professional get credit for that. Some of those would be sort of retrospective type KPIs because you wouldn't know, whether something was going to be denied at the time that the chart was broken down. But I think CDI professionals, just like attending physicians and attending healthcare providers, they want to do a great job, but sometimes you're constrained by the structure of the processes within which you have been placed.
Great points, Dr. Martin. So this concludes our third podcast. We have a couple of podcasts on YouTube. Check them out under aemedco.com. Just enter that information. If you have trouble, you can reach out to me through LinkedIn. And Dr. Martin, on behalf of AE and Associates, I want to thank you for your time, and I look forward to everyone working together in their facilities to transform CDI to more of a denials, what Dr. Martin coined the terms proactive, preemptive denials avoidance approach. Our physicians will appreciate it. Certainly our patients will appreciate right level of care for the right reason at the right time with the right documentation, and our hospitals will get paid with less denials. So thank you again, Dr. Martin. Appreciate your time, and we look forward to the next podcast.